Today we will be talking about the metabolic bone diseases, particularly that occur in children in pediatric practice. What are they? First, for nutrition, you need vitamins, minerals, metals, hormones play a major role, enzymes, and even muscles, skeletal muscles. The most common deficiency disease that we used to see, not anymore, but still cases do occur, is rickets. Rickets, the etiology is, could be dietary, lack of intake, malabsorption. All right, the patient is taken, but it is not absorbed properly. It is absorbed properly, but not utilized. Final metabolization in the liver and kidney is not proper because of various causes. And certain disorders due to deficiency of the enzyme may manifest as rickets, and excessive excretion of calcium and phosphorus can also produce rickets, and other miscellaneous causes that produce rickets. Again, to repeat, etiology of rickets is lack of intake, lack of exposure to the sun rays, because particularly in certain communities, the child is wrapped in clothes and is never exposed to the sun rays, year or two. And lack of absorption, lack of stage 1 metabolism that occurs in the liver, lack of stage 2 metabolism finally that occurs in the kidney, and lack of enzyme. Rickets occurs in growing skeleton, and if it is adults, we call it osteomalacia. Why call it rickets? Because it's rachitic bones. They break easily, they bend easily. That's why it's called rickets. Radiologically, you find generalized lucency. Occasionally, you may see even increased density, particularly if it is renal rickets. Ground glass appearance of bones. The differentiation between the cortex and the spongiosum is gone. Physical lucency, the space between the epiphysis and metaphysis is increased due to excessive osteoid. Metaphyseal cupping, again due to excessive osteoid, this produces cupping of the metaphysis. Classical example of rickets in the knee, growing ends of the bones, metaphyseal cupping, and there is physis, namely the space between the metaphysis and epiphysis is increased, and there is a brush-like appearance. These are all the columns of cartilage that are mineralized, and in between there are non-mineralized columns of cartilage. And look at the epiphysis. The cortex is not seen well. It's all a ground glass appearance. This is classical of rickets. Again, these bones are soft. That's why they bend easily. Look at the lower ends of the bones of the legs. They are bent. And you may get genu valgum or genu varum deformities also. I said earlier, there is paintbrush metaphysis, osteoid seams, namely radiolucent areas, as if there is a break in the bone. Absence of lamina dura in the teeth, delayed growth and maturation. These children, they show slow maturation and delayed growth. And as though to compensate for the weakness of the bones, as though to compensate for the bent bones, there is a periosteal reaction and the concave aspect. Deformities of the bones, frontal bossing, rachitic rosary, beaded appearance along the costal cartilage margins, again due to the excessive osteoid. Fractures occur easily, and eventually, if untreated, secondary hyperparathyroidism takes place. These are the ribs specimens of the costal cartilages. Look at the cupping, the brush-like appearance, and the excessive osteoid. Clinically, they show as beads, rosary beads, bilateral, symmetrical. And thickening of the skull, look at the frontal bone, craniotabes they call it. It is softened. If you press it, softening of the frontal bones. And bending of the tibia. Look at the lateral curve of the tibia and fibulae. Again in the hands, almost similar appearance. Osteopenia, cupping of the metaphysis, delayed maturation, almost no ossification centers in this 1.5-year-old child. At least 2 centers should appear there. Again, to show the genu-varus deformity with the bending of the femora and tibia. Although there is straightening of the bones, straightening of the legs, still, if you look at the bones, they are osteoporotic. And then there is not much of distance between the epiphysis and metaphysis, but there is a sclerotic zone as though it is healing rickets. Renal rickets, marked deformity at the wrists. Look at the fractures and deformity due to renal tubular deficiency. You get this secondary type of rickets. Again, another case of renal rickets in a 12-year-old child. Look at the density of the bones. I said earlier, sclerosis you may see in renal osteodystrophy with rickets, increased distance between the epiphysis and metaphysis due to hypertrophy of the osteoid tissue and brush-like appearance. There is another entity called familial hypophosphatemic vitamin D resistant rickets. You may give vitamin D, but still there is no healing phase. Dominant familial sex-linked transmission. Radiologically, what you see is short, broad tubular bones. They resemble achondroplasia. Ossicles, multiple ossicles at wrist, sclerosis of bones, calvarial hyperostosis. Again, notice mild form of rickets, minimal cupping, and this lateral beaking, although we say it occurs in scurvy, so-called Pilgrim's lines, but here also you can get beaking on at the margins of the metaphysis. Hypophosphatemic rickets. There is some sclerosis around the epiphysis, metaphyseal sclerosis, but note the increased distance between the epiphysis and metaphysis. Frankly, given film, you cannot tell the etiology of rickets. Often, we simulate the other nutritional rickets, enzymatic deficiency, renal tubular deficiency, all these may simulate each other. As often is said, vitamin D is not really a vitamin. It is a pro-hormone, including D2 and D3. Now we come to the second entity called scurvy due to vitamin C deficiency. Earlier it was vitamin D deficiency, and here it is C deficiency. It's not as common as it used to be, but still in slum areas and undeveloped areas, in rural areas, you may get this scorbutic type of picture. See, the film is of course underexposed just to show the soft tissue swellings, because often there is hemorrhage in the joints. And look at the sclerotic zone at the metaphyseal end. Proximal to it is the lucent zone and corner spurs, which is typical of scurvy. Also, I would like you to notice the epiphysis. You remember the epiphysis in rickets? They are irregular. Cortical outline is not present. Whereas here, cortex is nicely outlined, but the central portion is lucent. And again, occasionally you may see both combination of scurvy and rickets. But scorbutic changes, namely metaphyseal sclerosis, proximal to lucency, and pelican spurs are classical. Another case of scurvy. Here you see metaphyseal sclerosis, that is, the patient thinking that it is a rickets, the patient must be receiving vitamin D, but that's not enough. Vitamin C is essential. Subperiosteal hematoma, displacement of the epiphysis, as though the patient, actually the radiological findings may simulate parent abuse trauma. Parent-infant trauma may cause similar subperiosteal hemorrhages, displacement and dislocation of the epiphysis. Both are due to subperiosteal hemorrhages. Again, diffuse subperiosteal hematoma along the femur. But if you look at the epiphysis of the tibia and femur, they are ring-like epiphysis. That is classical of scurvy. Again, ring-like epiphysis, the sclerotic zone is a little more prominent rather than the lucent zone, scurvy. Notice both the legs, it's not bowing, it's the way the picture is taken. Soft tissue swellings are there due to hemorrhages, but these are again subperiosteal hemorrhages, but not calcified in order to demonstrate in the film. Now we come to the deficiency of the enzyme, hypophosphatasia. And there are several varieties: neonatal, infantile, childhood and adult. As the infant grows to childhood and adult stage, the symptoms are less. The radiological findings are less severe. Marked bowing of the tibia. Look at the metaphyseal brush-like appearance, and look at the epiphysis also. This is what I was telling you, tor baby, in the sense there is no enough calcification and ossification of the bones of the calvaria from head to foot. Again, in the elbow and wrist, it simulates rickets. Nothing that you can say, oh, this is hypophosphatasia. Rachitic-like picture you can see. In infantile type, again rachitic changes. Skull sutures are wide. Soft tissue calcifications may occur. This differentiates from rickets. See, although there is cupping, there is irregular cupping and proximal sclerosis. If you look at the bones, they are well ossified. There is no osteopenia. But if you look at the wrists and elbows, there is marked irregular cupping. Childhood, radiolucent metaphyseal bands, metaphyseal defects that I have shown you earlier, bowing deformities, and craniosynostosis. Earlier, there was widening of the sutures. Now it is sutural fusion, premature sutural fusion. Again, hand, deep cupping of the metaphysis. And we'll come to the entity called familial hyperphosphatemia. This is different. It's not hypophosphatasia, hyperphosphatemia. We're talking about metabolic conditions. Children and young adults, they manifest autosomal recessive, mainly hemopoietic skeleton is involved, increased alkaline acid phosphatase, and increased turnover of skeletal collagen. What are the radiological findings? Wide cortex, and which is also dense, thin primitive trabeculae, modeling deformities, cysts in the metaphyses, thick skull, particularly the skull that has developed from membranous portion. And some people call it juvenile type of patches, because radiologically the skull bones and even the limb bones appear dense and bigger, simulating patches. Look at this. Increased density, deformities, and some periosteal reaction is also noted at the concave end of the radius. Looks like almost like a marble bone disease, diffuse density of the bones, and if you look carefully, there is widening of the bones also. Again, skull, multiple woolly appearance, as though you are seeing in Paget's, but Paget's does not occur in children at this age. Limb bones, forearm bones, they are widened, thickened, medullary encroachment, and denser. Another entity, enzymatic problems, primary hyperoxaluria or resulting in oxalosis. Glyoxylate, glutamic glyoxylic transaminase glycine. This is deficient. There is type 2, there are two types. Type 2 L-glycuric aciduria, defect in D-glycuric dehydrogenase, oxalate and L-glycolate is present in the urine. Absence of symptoms until renal insufficiency occurs. Actually, we have seen cases where we thought it is renal disease with secondary hyperparathyroidism simulating renal osteodystrophy until you go into the depth of laboratory studies of the oxalates. Pathology, calcium oxalate crystals are deposited in the kidneys, myocardium, vessels, muscles, and in spongy bone. That's why you get sclerosis. Polarized light microscopy, you see multiple thin needle sharp crystals. Radiological picture, coarse rarefaction of metaphyses, cystic changes in the metaphyses, sclerotic metaphyseal dense bands. See those dense bands, almost looking like what you see in lead poisoning, but lead poisoning you don't see that thick dense band. You see thin bands which are dense, but not that thick, metaphyseal bands. Again, metaphyseal bands in the wrist. Also note the cortical sclerosis in the carpal bones. Cystic appearances, we have mentioned earlier, metaphyseal cystic lucencies and dense sclerosis of the shafts. Same appearance, a bone in a bone, the epiphysis, density, typically are thickened, at the same time cystic changes in the metaphyseal ends of the bones. Diffuse calcification of the renal parenchyma because of the calcium oxalate crystal deposition, and the bones of the spine also are dense and sclerotic. The posterior ends of the ribs are bulbous, thickened and calcified. Now we come to Wilson disease, where there is serum ceruloplasmin is low. Skeletal findings, it may simulate rickets or in adults osteomalacia. Osteopenia or osteoporosis is present. Fringed articular margins that you don't see in many of the conditions. The articular margins are the carpal bones or the limb bones. They are fringed, irregular, and sometimes they are fragmented. Because of the fragments, ossicle formation may also be noted. Look at the knee joint. Look at the articular margins. There are defects in the articular margins and sclerosis. Particularly if you look at the medial condyle of the femur, it looks like early osteochondritis dissecans. That can occur in Wilson disease also. But it's not just localized. Look at the articular ends of the tibia also. Similar changes are seen. If you notice, the smooth margin of the articular end of the lower end of the femur or upper end of the tibia, articular margins, they are irregular, fringing. That finding is important to diagnose Wilson disease. Ossicles we were mentioning at the ulnar styloid process, multiple ossicles because of the deficiency in the calcification of the cartilage. Subchondral cysts you may find, calcification of the fibrocartilage, chondrocalcinosis, osteochondritis dissecans, that which I mentioned earlier, chondromalacia patella, Scheuermann spine with multiple small snodes and irregularity of the apophysis, premature degenerative joint disease wherever there is effect. Rickets-like picture in Wilson disease. Look at the increased lucency between the metaphysis and epiphysis, ground glass appearance of the bones. Patella, look at the articular margin, it's all sawtooth-like, fine, irregular appearance. Same thing in the knee, rickets-like appearance. Non-skeletal, of course earlier it used to be called hepatolenticular degeneration. Intracranial calcifications are noted and dilatation of the ventricles is noted. Portal hypertension and esophageal varices are also occasionally be noted. These are the Kaiser-Fleischer ring, the brown color, brown pigment along the limbus, and of course note the discoloration of the nails due to copper deposition. Then we come to homocystinuria, or deficiency of the cystathionine synthetase, another enzyme. Radiological osteoporosis is present, kyphoscoliosis, concave vertebral end plates, posterior scalloping of vertebrae you may see. That's why occasionally it's difficult to differentiate between morphons and homocystinuria, microcephaly, large sinuses, thick calvarium, and sternal deformity, say pectus excavatum or pectus, bulging pectus, breast, pigeon breast type of appearance. Eye, ectopia lentis, downward and medial, whereas in morphons it's upward and lateral. Ophthalmos, staphyloma, retinal detachment and optic atrophy. Peripheral skeleton, that's what is important for us. Long and thin gracile limb bones. Humerus varus, coxa valga, enlarged ossification centers, enlarged carpal bones, metaphyseal spicules you can see. Not fringing that you saw in Wilson's, spicules. Arachnodactyly, simulating again Marfan syndrome, restricted joint mobility, kyphoscoliosis, rocker bottom feet, Charlie Chaplin type of gait where the toe is out. Look at the wrist. There is osteopenia. There is enlargement of the epiphyseal centers. Metaphyseal spicules I'll show you. Again, the spine, osteopenia, butterfly type of vertebrae, and the slight posterior scalloping. Fishmouth type of vertebrae that you see in Cushing syndrome and other osteopenic conditions. Now we come to Gaucher disease, that is deficiency of cerebrosidase. All these genetic abnormalities could be corrected with supply of proper enzyme. Deficient beta-glucosidase disease, 3 genetic forms, type 1, type 2, type 3, they're all clinical forms. Clinical adolescent young adults, kerosene accumulation, and then laboratory-wise elevated serum phosphatase, Gaucher cells and biopsy. Radiologically, this is important for us. How do you diagnose Gaucher disease? Although rare in India, but still occasionally we come across. Infarcts, because the Gaucher cells occlude the vessels. Ischemic necrosis of the articular ends, reactive new bone and periosteal reaction, scalloping of endosteum, proliferation of the cells in the spongiosa, that's why there is scalloping, splitting of the cortex. Sclerosing sacroiliitis, bilateral sacroiliitis, rarely skull is involved, expanding lesions in ribs and other tubular bones. In the mandible, you may find cystic lesions composed of multiple Gaucher cells. It is an infiltrative disease. Lack of tubulation of the lower ends of the femur, osteopenia is present in this infant. As I said, osteoporosis of tubular and long bones, lucencies, medullary lucencies, infarctions, fractures, and occasionally from infarcts, a complication of osteomyelitis or even malignancy, osteosarcoma may arise, but that is rare. Lack of modeling of the lower end of the tibia particularly. Of course, lucency because of the marrow involvement. This is typical of Gaucher disease. Lack of modeling can also occur in many conditions like osteopetrosis, pycnodysostenosis, and Erlenmeyer vascular deformity of the lower ends of the femur they described. But this associated with osteopenia and incidentally if there is an infarct or osteonecrosis, you can think of Gaucher disease with hepatosplenomegaly. Again, lack of tubulation. Other metabolic causes, fluorine, increased fluorine either by ingestion or even by inhalation. You can get fluorosis. Medications, heparin and barbiturates, anti-epileptic drugs, and other poisons like lead poisoning, bismuth, arsenic. Toxic effects on skeleton: fluorine, lead, aluminum, phosphorus, arsenic, bismuth. Hypervitamin A or even D. Enthusiastic mothers may give a lot of cod liver oil. Earlier they used to give. With lots of cod liver oil, you may get excessive vitamin A and D and produce toxic symptoms. Fluoride excess, 1 is 0.8 per part. Length of time is important because if the water is taken only for a few months, you may not get it. But if it's a few years, 5 to 10 years, certainly you get skeletal changes. What are the radiological findings? Increased bone density. But to begin with, there is osteopenia and also ricket-like changes. Rickets. Why rickets? There is increased space between the metaphysis and epiphysis. And at the same time, the bones are dense, the trabeculae are thickened. Again, you may get geno-valgum type of deformity, rachitic-like changes, multiple, they used to call lines of arrested growth, but it's not arrested growth. Even increased part of growth can produce those parallel lines along the metaphysis of the tibia. Growth lines, they call it. Clinical picture, in adult, of course. Same findings in the forearm bones. Again, in the pelvis. Increased density along the metaphysis. Lead poisoning. Any arsenic, bismuth poisoning, because the children take lead-coated toys and suck them, or paints containing lead, they may put it in the mouth. Another case of lead poisoning. Hypervitaminosis A, you may get a periostal reaction or arrest of bone growth. We'll show you the examples. Periostal reaction along the ulna. Somehow ulna is because suppose it is exposed to the outside, and you get periostal reaction mostly along the ulna. This is what I said, arrested growth, the cone-shaped metaphysis and epiphysis due to the arrested growth. Bilateral, symmetrical. Similar case. Cone-shaped epiphysis you can get in ischemia and sickle cell disease and burns, wherever there is occlusion to the vessels. Hypervitaminosis D, dense metaphyseal bands, such as you see in lead poisoning or oxalosis, sclerosis of bone, cortical thickening, and soft tissue calcifications. This is, the patient had rickets, you see the deformities, but a lot of vitamin D is given. That's why there is increased sclerosis. The deformities persist, but the sclerosis of the bones is increased. And if you see the peripheral bones, there is osteoporosis. All that calcium is taken out, sucked in, and put into the growing ends of the bones excessively. Dilantin and other barbiturates can produce rickets in adults, osteomalacia. Alteration of hydroxylation of vitamin 3 that occurs in the liver. Fetal abnormalities, the mother gives to the birth to children. Hypoplasia of terminal phalanges and pseudo-hyperphalangism. These are the two manifestations in the children born for mothers who have taken long-term barbiturates. Again, rachitic-like appearance, widening of the physis and density of the bones, renal osteodystrophy. Corticosteroids, osteoporosis, osteonecrosis, and neuropathic type of joints. Look at the spine, again fish mouth type of vertebrae. This is a classical of osteoporosis with wedging. It's not anterior wedging that occurs in senility or in children due to trauma, leukemia, or tetanus, but it is a fish mouth-like type of vertebrae. Because the bones are softer, the disc bulges and produces that concavity. Osteonecrosis in the heads of the humeri. Bilateral osteonecrosis and corticosteroid therapy, either for asthma or for other allergic conditions. and just osteoporosis. What are metabolic causes? Calcium and phosphorus deficiency, copper deficiency, protein deficiency, vitamin C and D you have seen, homocystinuria also you have seen osteoporosis. Immobilization osteoporosis. Patient had, say, a fracture of the femur and then immobilized in a cast, you can get immobilization type of osteoporosis, usually to that localized limb with metaphyseal bands of lucency. Reflex dystrophy. This is what is called RSDS, reflex sympathetic dystrophy syndrome. Either in immobilization or due to nerve injury, you can get diffuse osteoporosis, common in feet, but you can also get in hands. So conclusions, these some of the, not all the metabolic disorders are included, but some of the adult metabolic disorders are also included in order to impress upon you so that you can appreciate the changes that occur in the skeleton. Mostly either osteoporosis or osteomalacia or rickets in children or excessive deposition of either metal or calcium.